Welcome to this video in which we shall discuss the pharmacotherapy of glaucoma. An intraocular pressure of 21 millimeters of mercury is considered abnormal. However, there are patients with intraocular pressures much higher than 20 millimeters of mercury without glaucoma, and we call them ocular hypertensives. There are also patients with intraocular pressures less than 20 with severe glaucomatous changes, the so-called normal or low tension glaucoma. Thus, the point to be made is glaucoma is obviously not synonymous with raised intraocular pressure. So what is it? And what is its relationship with intraocular pressure? The glaucomas are a group of progressive optic neuropathies characterized by degeneration of the retinal ganglion cells and the resulting changes in the optic nerve head. Now, a reduction of intraocular pressure by 30% can reduce disease progression even for normal tension glaucoma patients. So that's the relationship between glaucoma and intraocular pressure. Therefore, management of glaucoma involves reduction of intraocular pressure either pharmacologically or surgically. Now, we need to understand that broadly speaking, glaucoma can present in two ways. The chronic form, where the iridocorneal angle remains open in general, and the acute form, where the iridocorneal angle gets closed. Chronic open angle glaucoma is chronic and progressive. Patients are dealt with on an outpatient basis, and many a time it may even be asymptomatic in nature. On the other hand, acute angle closure glaucoma is an emergency where the signs and symptoms present very dramatically, and the patient will be brought to the emergency department. Now, before we move on, let us brush up our knowledge about the anatomy of the eye from the point of view of pharmacology. So, there is the sclera, that's the scleral spur. This would be the cornea. This is obviously a sagittal section of the eye, and what you are seeing is the triangular cut section of the ciliary body. These blue structures, which are connected to the scleral spur, or rather which are inserted into the scleral spur, are the longitudinal fibers of the ciliary muscle. These would be the circular fibers of the ciliary muscle, and these would be the oblique fibers of the ciliary muscle. This red structure here is the superior iris, and this would be the inferior iris. The iris has got those green muscles over there, which are cut sections of the sphincter pupillae, and that's that yellow muscle which you see inserted into the free border of the iris is the dilator pupillae. That, of course, is the lens, which is held in position by the suspensory ligaments. That would be the trabecular meshwork, and this would be, that's the trabecular meshwork, and this would be the canal of Schlemm. As we mentioned, the longitudinal fibers of the ciliary muscle are inserted into the scleral spur. M3 receptors are, of course, present in the longitudinal fibers of the ciliary muscles, and upon stimulation, these fibers contract and the iridocorneal angle opens up. Here again is the diagram with both the superior ciliary body and inferior ciliary body are represented. And let us take a look at the circular fibers of the ciliary muscle in both the superior ciliary body and the inferior ciliary body. Now, if the eye was not cut and if it were intact, let us take a look at the superior ciliary body and see how the circular fibers of the ciliary muscle actually are arranged. Now, in the intact eye, you would have to imagine the circular fibers of the ciliary muscle emerging from the screen towards your face, and then making a U-turn, going down, and then moving back towards the screen, towards the inferior ciliary body. And then it meets the screen and pierces the screen, moving away from your face. And then it makes a U-turn upwards this time, and then moves towards the screen and meets the screen at the superior ciliary body. So in the intact eye, this is an intact circle. And when that circular muscle contracts, when the circular fibers of the ciliary muscle contract, they reduce the radius of the eyeball, causing the lens ligaments to relax. And this results in anteroposterior bulging of the lens. So M3 receptors are present in the circular fibers of the ciliary muscle. Upon stimulation, the circular fibers of the ciliary muscle contract, the lens ligaments relax, and the lens bulges anteroposteriorly. Now again, looking at the sphincter pupillae, if we look at the sphincter pupillae in the superior iris, and we imagine that this is no longer a cut section of the eye, but the intact eye, we would have to imagine those fibers again moving out of the screen towards your face, making a U-turn, going down, and then moving away from your face towards the inferior iris, and then piercing the screen, moving away from your face, making a U-turn upwards, and then coming back towards the screen and meeting the screen at the superior iris. So this too, in the intact eye, is a complete circle. And when that circle contracts, when the sphincter pupillae contracts, it results in miosis. Okay, so having revised that particular anatomy, let's move on to the physiological maintenance of intraocular pressure. The intraocular pressure is largely determined by the aqueous humor, and a balance should exist between the rate of production of aqueous humor and the rate of its drainage. If there is excess production or poor drainage or both, there is excessive intraocular pressure. So, what we are looking at here is the posterior chamber of the eye, and this would be the anterior chamber of the eye. Aqueous humor is produced by the ciliary epithelium that is seen in the ciliary body, both the superior and inferior ciliary body. The aqueous humor flows from the posterior chamber via the pupil into the anterior chamber, from where it exits the eye via 3 routes. The principal route, through which 90% of the aqueous humor drains, is called the trabecular pathway. The aqueous humor flows through the trabecular meshwork into the canal of Schlemm and then proceeds into the episcleral vessels or episcleral veins. 10% of the aqueous drains via the uveoscleral pathway, where the aqueous passes across the face of the ciliary body into the suprachoroidal space. From the suprachoroidal space, it is drained into the venous circulation. Whatever that remains can also drain via the iris. Now, the iridocorneal angle is important to be paid attention to, especially when we talk about glaucoma. In some glaucoma patients, the iridocorneal angle may remain open, but there may be a resistance to the outflow of aqueous humor through the trabecular meshwork. And if there are no secondary causes for this, it is called primary open angle glaucoma. Now let us move on to the pharmacotherapy of chronic open-angle glaucoma. The drugs used for chronic open-angle glaucoma may be classified broadly into four. There are some drugs which act via two mechanisms. They decrease the production of aqueous and they increase the uveoscleral outflow. There is one important class of drug under this group, and they are the alpha agonists. The alpha agonists may be classified into two, non-selective and alpha 2 selective. The non-selective ones would include, of course, epinephrine and dipivefrin, while the alpha 2 selective drugs include apraclonidine and brimonidine. The next group of drugs act by predominantly decreasing production of aqueous humor. These will include beta blockers and carbonic anhydrase inhibitors. Now, it is important to note that not all beta blockers are used in the treatment of glaucoma. Now, the non-selective beta blockers which are used topically in the treatment of glaucoma include metipranolol, levobunolol, timolol, and cartiolol. The selective beta blocker that is used in the treatment of glaucoma is betaxolol. Carbonic anhydrase inhibitors used in chronic open-angle glaucoma include acetazolamide, brinzolamide, and dorzolamide. Now, the next group of drugs are those that predominantly increase uveoscleral outflow only, and these include the PGF2 alpha analogs. The most important examples of which include latanoprost, bimatoprost, and travoprost. Finally, there are drugs that predominantly increase trabecular outflow only, and these include the cholinergic myotics. These can be classified broadly into two, those which act directly and those which act indirectly. The examples for directly acting cholinergic drugs would include pilocarpine and carbachol, while the only important example for indirectly acting cholinergic myotics include ecothiopate. Now, regarding the alpha agonists, we use them in glaucoma. There are two types, non-selective and selective. We saw this. We spoke about epinephrine. It lowers the intraocular pressure by reducing aqueous formation and increasing uveoscleral outflow, but it is not a good choice because it has got very poor corneal penetration and causes stinging of the cornea. Dipivefrin, on the other hand, is a prodrug of adrenaline, and it can penetrate the cornea. It enters the eye and gets hydrolyzed by esterases present in the eye and gets converted to epinephrine. However, dipivefrin still causes ocular stinging and other adverse effects, and therefore is still very unpopular. The selective alpha 2 agonists include brimonidine and apraclonidine. The mechanism is the same. Apraclonidine can cause lid retraction, and both brimonidine and apraclonidine can cross the blood-brain barrier in infants and therefore can cause CNS depression and apnea in infants. Now, we spoke about the beta blockers and the important examples for the non-selective and selective beta blockers specifically used for glaucoma. We spoke about how they inhibit the production of aqueous humor. However, the exact mechanism by which they reduce aqueous humor production is uncertain and still under investigation. The prototypical carbonic anhydrase inhibitor is, of course, acetazolamide, and it is available topically and systemically. Carbonic anhydrase inhibitors available exclusively as topical agents include dorzolamide and brinzolamide. And as we mentioned earlier, its mechanism of action is obviously reduction in the production of aqueous humor. Now, topical Carbonic anhydrase inhibitors, as we mentioned earlier, include brinzolamide and dorzolamide. There is one carbonic anhydrase inhibitor which is given systemically but has got predominantly ocular effects. And the example of that carbonic anhydrase inhibitor is methazolamide. Moving on to prostaglandin analogs. Now, these drugs have largely replaced beta blockers as first-line medical therapy for chronic glaucoma, at least, due to three reasons. Firstly, once daily dosing is sufficient. Secondly, the systemic side effects are very less comparatively, and it has got potent intraocular pressure lowering effects. The examples, as we discussed, include latanoprost, bimatoprost, and travoprost. And as we discussed, the major mechanism of action is enhancement of uveoscleral aqueous outflow. It's worth noting that PGF2 alpha analogs like latanoprost can cause heterochromia iridis, which is iris pigmentation, and hypertrichosis, which is excessive eyelash growth. Now we come to the topical myotic agents. We spoke about the classification earlier. Now, topical cholinergic myotics produce miosis by stimulating M3 receptors present in the sphincter pupillae. However, this in itself has little to do with reduction of the intraocular pressure. We need to remember that M3 receptors are also present in the longitudinal fibers of the ciliary muscle. And when M3 receptors there are stimulated, this causes the longitudinal fibers of the ciliary muscle to contract. And this causes the iridocorneal angle to open up. Aqueous humor drainage is thus increased via the trabecular pathway. Topical myotic agents were historically important glaucoma medications, but less commonly used. They were formerly a mainstay, but its use has declined due to the numerous side effects, the need to use them multiple times a day, and other reasons. As we mentioned, they do not affect aqueous production. They cause opening of the iridocorneal angle and increased drainage via the trabecular pathway. Even though they lost their place in chronic open-angle glaucoma, they briefly did retain an important place in the treatment of acute angle closure glaucoma. However, they have also lost their place even in acute angle closure glaucoma because in certain cases they can paradoxically result in shallowing of the anterior chamber and further closure of the chamber's angle. So they are no longer recommended in the treatment of acute angle closure glaucoma. Right, now let's move on to the medical management of acute congestive glaucoma or angle closure glaucoma. What we discussed earlier was chronic open angle glaucoma. As we discussed, that is usually asymptomatic and has a very insidious onset. It is usually diagnosed only when there is a high index of suspicion or if someone is looking for it. Acute angle closure glaucoma, however, is abrupt in onset. It is painful. The patient may complain of a severe frontal or supraorbital headache. There will be associated symptoms like blurred vision, nausea, and vomiting, and can result in severe visual impairment if not treated quickly. It is a true ocular emergency, and the presentation is quite dramatic. On examination, we will see a fixed mid-position pupil with a hazy, so-called cloudy or steamy cornea with conjunctival injection most prominent at the limbus. The affected eye is rock hard. The intraocular pressure may exceed 60 to 80 millimeters of mercury in an acute attack. And the presence of the characteristic symptom complex, a cloudy cornea, fixed mid-position pupil and rock-hard globe is diagnostic. Addressing the extraocular manifestations of acute angle closure glaucoma is critical. This includes analgesics for pain and antiemetics for nausea and vomiting. The pain and vomiting in itself can drastically increase the intraocular pressure beyond its already elevated level. So it's a good idea to administer the patient analgesics for pain and antiemetics for nausea and vomiting. Once diagnosed, the initial intervention includes the administration of a topical alpha-2 agonist, a topical beta blocker, and a systemic carbonic anhydrase inhibitor. Now, if the intraocular pressure does not drop significantly with resolution of associated symptoms within 1 hour of administering these drugs, IV mannitol should be given if there are no contraindications. Finally, to conclude, there are some newer drugs in the management of glaucoma. They include latanoprostene bunod and a Rho kinase inhibitor and a NET inhibitor, the example of which is netarsudil.